Well, thank you, Mo. It's always great to be here. It's one of my favorite meetings, and sorry I missed last year. So we're going to talk about heart failure, and although you heard that I was one of the co-authors of the guidelines on heart failure, I am not going to spend any time on guidelines. Can I have my slides up in a second here? Instead, what I want to do is make it a more practical talk. And running a heart failure program, I just want to give you some practical ways, because most of the guidelines, and I think a lot of the controversy you heard about, guidelines and risk estimators are terrific for populations. If you wanted to know how many heart attacks are going to occur in Reading versus Chico, you could put those numbers in and get a pretty good idea. But if you have a patient in front of you, those guidelines and those epidemiologic studies fall short of what you need. And what you need is what you heard. It's the art of medicine. This is what I call being a doctor or being a nurse. It's taking a person in front of you and deciding, with this particular person, what do I do? So that's what I'm going to try to focus on, is saying, what do I do in heart failure? These are my disclosures. None of these have any reference to today's talk whatsoever. First, let's define heart failure. I can tell you when we sat around, it took us over 2 years to write the guidelines, the first guidelines for heart failure. We spent 6 months trying to decide what the heck heart failure was. Okay? And the problem there is that heart failure is not a disease. It's easy to define what malaria is, but when you have a syndrome, it's very difficult to actually decide what meets the criteria for this syndrome to categorize this person as having heart failure. So that's the first thing you have to understand. This isn't a disease. It'd be like me saying, let's treat fever, and then we would decide what is fever. You'd have to come up with some criteria for that. So the criteria in a nutshell, and there are various different definitions. This one is kind of an evolution of my old mentor, Gene Braunwald, in terms of what's happened over the next few decades. It's any condition in which the heart fails to deliver an adequate volume and pressure of blood without flooding the lungs of the body. And you can see there are a lot of ifs and ands in there because you can't simply put down in 2 words what is heart failure. Nonetheless, if you use that definition, 20% of us in this room will have heart failure in our lifetimes. It's one of the most common cardiovascular conditions. It's less common than heart failure. You heard if you live long enough, you have a 90% chance of having, less frequent than hypertension. You have a 90% chance of developing hypertension, but you have a 20% chance of developing this clinical syndrome of heart failure. And depicted left to right, and these are 26-year follow-up in patients in the Framingham study. So these were adults who were enrolled in Framingham, and if you didn't have heart failure at 40 or 50 or 60 or 70, by the time you died, you still had a 20% chance. And this is one of those diseases that's not gender specific. It doesn't matter whether you're a man or a woman. The type of heart failure, as we'll talk about, is a little different between the genders, but the likelihood of heart failure is the same. And that's because the contributors, and notice I didn't say causal agents here, these are the contributors to heart failure, and they are ubiquitous in our society. Hypertension, you heard already from Chris Mendy how frequently that occurs in adults in the United States. Myocardial infarction, although it's declining, it's still an important cause of the eventual appearance of heart failure. Diabetes, obesity, smoking fortunately less common in California. Genetic influences, some nutritional issues, more commonly outside of the United States. And then infections, things like, did you happen to have a virus that afflicted you? Or were you exposed, not on this list, to toxins like adriamycin, for example, for chemotherapy? All those things can contribute to dysfunction of the heart. I will say that we used to, about a third of people with systolic heart failure, we used to lump as idiopathic dilated cardiomyopathy. And it turns out, you heard about genes a moment ago, this is one area of explosive knowledge growth recently, and that is about 2/3 of people who carried a diagnosis of idiopathic dilated cardiomyopathy actually have a genetic form of cardiomyopathy. Unfortunately, we used to think, maybe it's 1 or 2 genes. It's hundreds of gene mutations in scores of proteins that are in the contractile apparatus in the heart, and any abnormality there has the potential to muck up the contractile ability of the heart. So we do routine gene testing in our idiopathic dilated cardiomyopathy patients, and literally 2/3 of the time, we find a specific gene defect, which has not yet led to any change in what I'm going to tell you about how to manage heart failure, but our hope is that it will, because your heart proteins turn over very, very frequently. Every 2 weeks, 100% of your heart proteins have been replaced. So in theory, if somebody had a mutation in the titin gene, which is one of the most common genes that's defective, or the lamin protein gene, we could reinsert a gene there and cure their heart failure in 2 weeks. Okay? Sounds great, hasn't happened. People have been trying to do that for 30 years. We haven't been able to do it, but at least it offers us the glimmer of hope of a cure for those particular patients. Now, why does the syndrome of heart failure develop? So the contributing causes are hypertension, obesity, genetics, etc., but what is actually the cause of the clinical syndrome? Well, it's simply failure of the pump. The pump can fail in the systolic way. That means it doesn't squeeze as well as it's supposed to, and about half of patients with the syndrome of heart failure have systolic dysfunction. It used to be the most common cause of systolic dysfunction was myocardial infarction. I already said MIs are going down. So increasingly, it's a primary dysfunction of the heart muscle, be that genetic or toxic or whatever, that is an increasing cause of systolic heart failure because MIs are being better treated and better avoided. But you could also have impaired filling of the heart. Remember, if the heart fails as a pump, it may not pump enough or it may not receive enough blood adequately to pump adequately to meet the needs of the body. So about half of patients with the clinical syndrome of heart failure actually have reasonable or normal systolic performance, but they have something wrong with the filling of the heart. And this can be abnormal filling due to valve dysfunction. 50 years ago, 100 years ago, mitral stenosis due to rheumatic heart disease would have been a common cause. We hardly ever see that anymore. It can be pericardial disease. And in some parts of the world, tuberculous pericarditis is still an important cause of a constraint around the heart impeding the heart's ability to work. Again, something we don't see that often in California. More commonly, the heart is structurally deficient so that it can't relax appropriately or allow blood to enter the heart easily. And we call that, some people call it diastolic heart failure. The name that actually has been ascribed to that is this heart failure with preserved ejection fraction. And that is what you will see in all modern descriptions of this. You can call it diastolic heart failure, but that's a little bit of a misnomer. It's better to just say heart failure with preserved ejection fraction. And we'll talk a little more about that in a moment. But what happens when you have either impaired systolic or diastolic function are the following consequences. And the one that is most apparent to the patient is that they're short of breath. And why are they short of breath? It's because their lungs get flooded, basically. People don't know that they have impairment of the heart's function. They just know that they can't do things they used to be able to do. Any impairment of left heart function, be it valvular, diastolic, systolic, makes no difference if it leads to increased venous pressures in the left atrium, the pulmonic veins, in the lungs get flooded, the lungs get stiff. You have sensors that pick that up immediately, and you will therefore have the sensation of breathlessness. So flooding of the lungs is the cardinal symptom that most people will complain about. But you can also have flooding of peripheral tissues, right? Peripheral edema. And that can occur due to any left heart dysfunction or any right heart dysfunction. It's sort of a more global issue. Unfortunately, peripheral edema, for example, is caused by lots of other things too. So it's a less specific sign of congestive heart failure than would be breathlessness, for example. And then unfortunately, when the heart begins to malfunction, hormonal influences change the instructions to the kidney, and the kidney is told to hold on to extra salt and water, and that leads to volume overload. And these constellation of things lead to the clinical symptoms of heart failure, or if you use the word congestive heart failure, that means that in fact there is volume overload. That's what leads to congestive heart failure. So simplistically, using here a depiction of the heart by echo, for example, and echo is by far the most important test to discriminate in terms of which of these types of heart failure causes is leading to the patient's findings. In a normal person, you have normal chamber size, normal cardiac mass and squeeze. And an important thing that we didn't know before until we had three-dimensional echo is that the heart twists. With every beat, a normal heart has torsion or twist, and it's much like if you take a mop and you twist the mop and the water squeezes out of it. Well, it turns out the heart twists about 15% along its axis. And very importantly, when it relaxes, it untwists. And that uncoiling is an active process that sucks blood into the heart filling chamber. It sucks blood into the pumping chamber, the ventricle. Hence, if you have impaired twist, meaning impaired systolic function, you're going to have impaired suction when the heart relaxes. And that's why 100% of people with poor systolic function have diastolic dysfunction, because the heart does not untwist, sucking blood from the atria into the ventricle, which is why it's kind of murky to try to define diastolic dysfunction in a patient with a low ejection fraction, because 100% of them have diastolic dysfunction. If somebody has valve dysfunction, obviously they can have perfectly normal heart muscle and perfectly normal twist and perfectly normal suction, but the pump is failing to adequately perfuse the body because valves are abnormal. That could be aortic regurgitation, mitral regurgitation, tricuspid regurgitation, and the treatment for that is to fix or replace the valve. So we're not going to talk about what to do for valvular dysfunction because the treatment is a surgical or now increasingly an interventional cardiologic procedure to replace or repair or otherwise somehow alter the mechanics of the valve so that the person's heart is not disadvantaged. What we're going to talk about is what to do when it's not valvular heart failure. And most of us, when we think about heart failure, we think about this picture, the systolic heart failure. The heart is more globular, it's more spherical. Each unit of heart muscle appears to function less well, and hence the overall performance of the heart is less by whatever criterion you're going to use. And most of us have used the criterion of ejection fraction, has stood the test of time. It's still a terrific number, and yes, it's dependent on lots of factors, but as a single number, it still has stood the test of time. So ejection fraction has been used in virtually every heart failure trial to define who gets in and how they benefit, etc. But increasingly, diastolic dysfunction has risen, as I said, this heart failure with preserved ejection fraction. And part of this is because fewer people are having heart attacks, fewer people are dying prematurely, our population is aging, older people have more chance to develop high blood pressure and all the consequences of that. And hence, the growth in heart failure will really be this category, heart failure with preserved ejection fraction, in which the heart muscle is not relaxing appropriately. And that's the prime reason the person presents with the constellation of signs and symptoms. And indeed, this is highly related to age, and therefore, the outcome of heart failure with preserved ejection fraction versus systolic heart failure is roughly the same, which is a surprise to most people. If somebody gets admitted to your hospital with pulmonary edema, and they have an ejection fraction of 30% versus 60%, you might think that the person with an EF of 30% would do more poorly than the person with an EF of 60. Turns out that isn't true. If you look at in-hospital death, 60 to 90-day death, even 1-year death, they're roughly the same. Now, one caveat, the people in purple here who have the impaired diastolic performance to heart failure preserved ejection fraction are substantially older. So one of the reasons they die sooner than you might expect is they're old people. And if you look at the percentage of heart failure patients sick enough to be admitted to the hospital, it's mostly older people who get admitted to the hospital who have preserved ejection fraction. And believe me, they can be very sick. They can present with pulmonary edema, overt pulmonary edema, end up on a ventilator in the intensive care unit with an ejection fraction of 60% due to this impairment of diastolic performance or some other restraint that prevents the heart from working. Now let's talk about the physical exam. I wish I had an hour to go through physical exam, but I don't, but I'm going to give you a few pearls. And the signs of heart failure are well known to you, and I mentioned the cardinal one is dyspnea. There also is orthopnea, breathlessness upon assuming the recumbent position, peripheral edema. We talked about weight changes, and I'll discuss this new term, bendopnea, which was coined by people, and this is something all heart failure doctors have been aware of, but nobody coined a term until a few months ago, which is breathlessness upon leaning over. And usually you've seen it, the person says, every time I bend over to tie my shoes, I can't breathe. Okay, and we'll talk about what that means. Of these signs of heart failure, bendopnea I'm going to just focus on for a second because this is new to most of us. So here's the study that just came out within the last few months investigating what does bendopnea mean. So it turned out these were people who were being admitted to a hospital in Texas for right heart catheterization as part of their heart failure management. And of the 102 sequential, they just took every patient coming in for right heart cath, 29 of them, so virtually a third of them had this complaint of bendopnea. So what was different about the people with bendopnea versus, no, I'm okay when I bend over, I don't have shortness of breath? Turned out they had higher right atrial pressures, higher pulmonary cavity wedge pressures, lower cardiac outputs, lower oxygen saturations. This was a sign of vascular congestion and worse heart failure. So we shouldn't ignore it, and many of you probably have in the past. You just say, you're getting old, or buy slip-ons or something, but this is a real sign, okay? So don't belittle the patient when they say, I'm okay and I don't have breathlessness except when I bend over to tie my shoes. That person probably needs more diuretic therapy, frankly. Now, in physical exam, you might be able, in fact, to corroborate that that patient with bendopnea is volume overloaded. And here are many of the things that we would historically have been taught in our examination classes, looking at their jugular venous pressure. Do they have RALs? Do they have an S3 gallop, an S4 gallop? Do they have murmurs? Do they have a hepatojugular, or better termed abdominojugular reflux? Do they have peripheral edema? Well, it turns out if you actually look at heart failure studies, not all of these are going to be that helpful in your decision making about what to do with a patient. So what are the most useful findings? For acute heart failure, they're all useful. That means if you're an emergency room doctor, these are all useful signs when somebody says they're breathless. Because if they're breathless from a pulmonary embolism or breathless because they have COPD or asthma, they may not have these findings, but these are typical findings for acute heart failure. But if you run a heart failure clinic and you have somebody who's had heart failure for 15 years, what are the signs and symptoms that are helpful for chronic heart failure? Only 3. RALs are useless, for example. Chronic heart failure patients don't have RALs. They develop terrific venous drainage and lymphatic drainage from their lungs. They can have a wedge pressure, the highest I've seen was 60. In fact, that was a direct left atrial pressure of 60, and the person had no RALs. So RALs are almost never heard in the chronic heart failure clinic. You could even argue don't even listen to the lungs, it's not helpful. It is for pleural effusion, actually, but that's about it. But jugular pressure, hepatojugular or abdominal jugular reflux, and peripheral edema are cardinal findings. And the reason I point this out is because I have never had, and for 11 years we had every third-year medical resident at UCLA rotate through my office, I've never had somebody at that stage of training who knew how to interpret a jugular venous pressure. It's sad, because you don't have to put a catheter in somebody. If you have eyes, you can get the jugular venous pressure in 95% of people. The only people you can't is people with really big, fat necks where you can't see a vein. If you can see a vein, you can use the external jugular. It's perfectly acceptable, so long as it's not increased in volume because of muscle constraints. So when you go to Gold's Gym and you see those big muscle builders and they have big veins popping out of their arms, that doesn't mean they have central venous hypertension, right? But if you can look and you see the nice undulatory dance of the jugular vein, and that's what it does. Unlike the arteries that have one pulse, which is the contraction of the heart, the jugular veins have 2 pulses, because you have the contraction of the atrium followed by the contraction of the ventricle. So if you look and you see this nice undulatory wave, that's the jugular vein. If you're sitting somebody up and you can see the jugular venous contour, they have elevated pressure, 100% of them. You never should be able to see the jugular veins when somebody's sitting upright, because normal jugular venous pressure is below the height of the clavicle when somebody's sitting. Conversely, if you lay people completely flat, you're not going to see the jugular pressure either, because it's already going to be above the angle of the jaw. So you have to have somebody at the right angle. Could be 10, 20, 30 degrees. Or in my heart failure patients, when I first greet them, I can look right across the room and see, aha, the jugular venous pressure is 14 centimeters. Because if it's at the level of the clavicle, it's 5, and if it's at the mandible, it's 20. And most of my patients are going to be between 5 and 20. So it's a very, very good barometer. And it turns out in recent analyses in heart failure clinics, if you just ask the question, do they or do they not have jugular venous hypertension, here are the mortality results. Okay, death is on the left. Death or heart failure, death is on the right. This is just death. I didn't put heart failure hospitalization, but it's the same. On the left is jugular venous pressure, and the right is peripheral edema. They are independent of each other, and both are useful prognosticators. So if you have somebody where they have central venous hypertension, they need more medicine. Right? So it's your job to figure out which medicines to use. And most of what I'm going to talk about today is which medicines can you use. But don't decry the physical exam. Don't throw away your stethoscope like Eric Topol says. Please use your eyes and your ears it's still helpful. And finally, before we talk about drugs, there will be new diagnostic tests that will help us who manage heart failure patients. I'm not going to mention echo because that has been around now for 40 years. It is terrific, and echo keeps getting better. MRI, however, has one advantage. If you have an MRI center that has the right software to look at the heart muscle, not the ejection fraction, but the heart muscle, you can look directly at the muscle. And here are people with systolic heart failure, and they're classified by MRI of the heart muscle to determine whether they have scar that looks like a heart attack on the upper two frames. These are people with transmural scars, versus on the lower frames, people who have a band of what looks like white on this picture, and that's scar in the middle of the heart muscle, mid-wall fibrosis. Now, the reason that's relevant is because we are in a continually cost-constrained society. And we can't afford, you heard earlier about pulmonary hypertension drugs, $180,000 a year. There are oncologic drugs that are $300,000 a year. There are cholesterol drugs that are $300,000 a year now. We can't afford to waste money. We have to be better at determining who's going to be helped by intervention A, drug B, or a device. So if you just do simple things like get an MRI and look at scar tissue, here's what you find. On the left is death. And we're looking specifically at the red at people that have low ejection fractions, but who do not have fibrosis by MRI. And look at the prognosis going from left to right over 10 years of follow-up. If you have a low ejection fraction, but you don't have scar tissue, you're basically going to do fine. If you're in the green, in which you have scar tissue, 50% of those people are dead in the next 2 years. Those are the people who need defibrillators and resynchronization therapy, a $50,000 device, or more aggressive therapy, or maybe transplant, or an LVAD. These are $300,000 things. So we have to be smarter. We can't just be crude and say, low ejection fraction, you need transplant, or you need this. We can begin to stratify patients and predict who's going to do well, who's going to do poorly, and use the big guns for those who are likely to do poorly, and then use the art of medicine for those whom we can keep out of the operating room suite. So first, I want to dispense with heart failure with preserved ejection fraction. You've heard that we should base our recommendations on outcomes trials, randomized, double-blind, placebo-controlled, etc. How many trials have been completed in heart failure with preserved ejection fraction that showed benefit? 0. Now, it's not that we haven't looked. I could put up here about 20 different things that have been used in heart failure with preserved ejection fraction. Spironolactone, angiotensin receptor blockers, ACE inhibitors, etc., etc. None of them have shown benefit in terms of mortality. Little increments in heart failure hospital stay maybe, but that's it. So most of our evidence about what I'm going to talk about is about systolic heart failure. So let's look at the treatments for systolic heart failure. Now, for making the patient symptomatically better, whether they have systolic dysfunction or they have preserved ejection fraction, the number one thing the patient will respond to most quickly is reducing excess volume. So their kidneys have been told to hold on to salt and water. They probably have 5, 10, 20, 30 pounds of extra water in their system. Some has leaked into their tissues of their legs, some into their liver, some into their belly, some into the lungs. If you get rid of that, the person will feel better and honestly do better, at least short term. So that means diuretic therapy, trying to countermand the instructions to the kidneys and tell the kidneys, please make more urine. Make more urine, get rid of the extra salt and water, and make the person euvolemic. Usually this means the so-called loop diuretics. They work at one portion of the glomerulus, and most of us historically have used furosemide. It is the cheapest of the loop diuretics. However, it is not the best loop diuretic by a long stretch. And in the heart failure clinic, we're much more likely to use torsemide, and that's because it has much better bioavailability. It's absorbed. You've all seen this problem. Somebody's on 80 of oral furosemide at home. They're grossly volume overloaded. They come in our office, they come into the office to get this, but in your place it may be to the emergency room or the hospital. They get a shot of intravenous furosemide and they urinate 10 liters of fluid over the next day. Okay, what does that tell you? It tells you the person wasn't absorbing furosemide because furosemide is bad, poorly absorbed. So that's part of the resistance, has nothing to do with the drug not working at the kidney, it's not making it through the mucosa of the stomach and the intestines. And hence, we prefer torsemide. Now, many times you need to combine diuretics because the person indeed is not responding as well as you'd like. So very commonly, if they're not diuresing appropriately, you give them one of the loop diuretics. And as I said already, my preference is torsemide. And then we add a second drug. And the second drug could be any of the thiazide-type diuretics, but the one that's used in most heart failure circles is metolazone. It's not used for hypertension control. It's a little more expensive. You could use chlorthalidone, for example, perhaps. And then increasingly, spironolactone. And I'll spend a little bit more time talking about spironolactone in a minute, because it really is a terrific drug, not just for hypertension, as Chris Mendy said, but also for heart failure. Let me just show you why furosemide, torsemide, and bumetanide, the three different loop diuretics, are different from one another. Left to right is the potency, meaning milligram per milligram, which is the strongest of the drugs. And the weakest of the bunch is furosemide. Off to the right, you have to give 10 to 100 times more furosemide to get a simple amount of excretion of sodium by the kidney. That's measured on the vertical axis. But if you notice the absolute magnitude of benefit, that is how much salt and water is excreted by the kidney, the strongest of the bunch is torsemide, and that's why we prefer that. And finally, even though these drugs work in the same thing in the kidney, they have different effects. And if you're aware of the literature, it turns out that in long-term studies, people that are on high doses of furosemide do more poorly. Now, we've always argued, well, that's because they're sicker people. If they are sicker, they need more diuretic, and there is an element of truth to that. But if you look at studies which have tried to tease this out, it turns out that if you look at scarring of the heart, and on the vertical axis is how much scarring of the heart, and I already mentioned to you that in idiopathic dilated cardiomyopathy, scar in the heart is a bad thing. This is a measurement biologically, biochemically, of scar formation in a randomized trial of patients undergoing cardiac biopsies. And what you see is that yellow is furosemide and the light blue or purple color is torsemide. More scarring occurs when you give furosemide. And it turns out that furosemide turns on scar formation. And that may be why furosemide patients do more poorly. So the patient feels better, they're euvolemic, but the cornerstone of therapy for heart failure shouldn't revolve around diuretics, because you may actually make the process worse in terms of scar formation in the heart, at least with furosemide. So we reduce excess volume, at least initially, with diuretics, maybe more than one diuretic. Preferable diuretic is torsemide. Salt and water restriction. You heard a little bit earlier about salt restriction for hypertension. I can tell you we spent a long time in the guidelines committee trying to decide, should we recommend salt and water restriction for heart failure patients who were volume overloaded? Seems kind of intuitive, doesn't it? But I will tell you, if you're using randomized clinical trials, you would not include that in the guidelines. Because at that time, there were no randomized trials. There has been one randomized trial since then, and it failed. When they sodium restricted heart failure patients, the patients did not do better. And the reason for that is they went from 2,500 milligrams of sodium per day to 1,500 milligrams of sodium a day. You want to restrict sodium, you heard earlier, what's the highest sodium intake in the world is in northern China, where they eat, on average, 6,100 milligrams of sodium per day. The lowest, we're here for a man in this audience, 4,000 is about typical in America. The lowest in the world isn't 4,000 or 2,500 or even 1,500. Lowest in the world is 38 milligrams per day. And that's in the Yanomamo Indians in the Amazon. And those people aren't dying of hypotension, I will guarantee you. So if you're going to salt restrict somebody, you need to restrict them not from 2,500 to 1,500. You need to bring them down to 500. And I'll tell you, most people will not take a 500 milligram sodium diet, because it means they can't eat any processed foods or canned foods or most frozen foods. It means they have to shop and do their own cooking, and most Americans don't do that. So do I think salt restriction might help? Perhaps. I do tell my patients, do not drink extra water. Well, gee, doc, I saw on Dr. Oz that I should drink 11 glasses of water a day, Do not do that. If you're a heart failure patient, you will flood the system. So we do restrict people, but I will tell you the level of evidence is not terrific that that is what you should do. So instead, what we try to do is to alter the biology of this process. Now, once the heart starts to struggle, and it doesn't matter what the struggle is, I mentioned all these neurohormones get increased. Epinephrine, norepinephrine, dopamine, aldosterone, renin, angiotensin, all of them go up. 100% of them go up. And that's a normal response, and it's necessary if a bear leaps out from behind a tree when you're on the trail. but it's not necessary when you're just minding your own business, watching television, eating Doritos, you know. So you have to therefore contemplate that if we can interrupt this adverse reflex system, maybe we can make the patients better. And the first notion that was then applied to patients with heart failure was interrupting the renin-angiotensin system using the first of the commercially available angiotensin-converting enzyme inhibitors, which was captopril. And of course, captopril was first introduced as an antihypertensive, but then it subsequently was found to have additional use. And it's important to understand, captopril, which we hardly use anymore, but if you use lisinopril, benazepril, whatever ACE inhibitor or ARB you use, in this population, we are not using them as antihypertensives. If you are a nurse, you know how many calls I've gotten from the nurses on our floor, well, Mr. So-and-so's blood pressure is 95, so I held his lisinopril. Well, the guy's ejection fraction is 15%. You know, I'm not using this as an antihypertensive. So remember, this is a disease modulator. It's not an antihypertensive. It is not used for afterload reduction. That term should be banished. We initially thought that because the blood vessels are squeezed, if you unsqueeze them, the heart will perform better. In fact, what's happening is you're interrupting these hormones that lead to fibrosis and other things. So many drugs are available in this category. My bet is they all work, although they have not all been tried. You need to use appropriate doses, and please remember, do not hold these drugs because the blood pressure is, quote, low. In most heart failure clinics, the typical systolic blood pressure is 110, which is way below what it is in the general population for age-matched controls. And we in our heart failure program do not get nervous unless the blood pressure is below 80 systolic. These people do very well at blood pressures of 90 to 100 or 110 systolic. Now, I mentioned that ACE inhibitors and ARBs have been proven. I'll show you in a moment the evidence for spironolactone, which is sometimes lumped into these categories even though it works a little differently. And the derivative of spironolactone, eplerenone, also in that category. Let me first talk about the database that supports the use of these agents. So here are the 6 trials in the world's history looking at ACE inhibitors for systolic heart failure. Remember, this is only for systolic heart failure. And on the vertical axis is the mortality reduction against placebo. So the people who were placed on an ACE inhibitor and the variety of drugs used in these trials had an average of 20% reduction in mortality over the duration of the trial. And you can see they're consistent. Little differences, did you have a heart attack, et cetera, et cetera. But the overall message is the same. The ACE inhibitors help. ARBs are equivalent. They are equivalent in terms of benefit, so you could use either, your choice. Before, ACE inhibitors were recommended because they were cheaper. Now we have generic ARBs, and so long as you use a reasonable dose, you can use either. I don't care. However, I mentioned reasonable dose. Here are looking at death or death with heart failure hospitalization at 43,000 heart failure patients from the one advantage of the Canadian health system is they have basically a centralized electronic health record. And so they just looked and said, okay, of 43,000 heart failure patients who were given either an ARB or an ACE inhibitor, how did they do versus what the dose that the doc wrote for their ACE inhibitor or the ARB? On the left-hand side is death. The first 3 bars are ACE inhibitors in increasing doses. The next 3 bars are ARBs in increasing doses. To the right are heart failure hospital stays. And what you notice in every category is the higher the dose was, the better the patients did. Now, this isn't a randomized trial. And there's only one randomized trial in the world that ever looked at this, and unfortunately used 5 milligrams of lisinopril versus 40 milligrams, and most people wouldn't consider that to be a very fair trial. But it showed the same thing. Higher doses are better. So unlike in hypertension, where 10 versus 20 of lisinopril isn't very different, in heart failure, higher doses are better. And that's true of ACE inhibitors, and it's true of ARBs, as best we can tell. Not from randomized trials, but from every epidemiologic trial we have looked at. Now, what about a different way of perturbing the renin-angiotensin-aldosterone system? Well, I mentioned to you that one of the hormones that's increased is aldosterone in heart failure. And spironolactone, a drug that had been used for a long time for high blood pressure, was then used for systolic heart failure. And the original trial is displayed here, looking at the vertical axis of death versus time, left to right, and there were fewer deaths in spironolactone. Notice the mortality reduction. I showed you with ACE inhibitors, the average was 20%. With spironolactone, the mortality reduction was 30%. That's half as good again as ACE inhibitors. And in fact, spironolactone has risen, and we now consider it to be a cornerstone therapy for systolic heart failure. Now, it turns out that this is not just due to blocking aldosterone. Aldosterone is a normal hormone we all make. It's made in excess. It binds to receptors called the mineralocorticoid receptors, and it was always thought that the reason heart failure patients benefited was because you blocked aldosterone at its receptor. Then it turned out we did studies blocking the production of aldosterone from the enzyme that makes aldosterone, and those drugs didn't work, even though the aldosterone levels went to zero. Turns out, in heart failure, the receptor is stimulated both by aldosterone and by cortisol and other steroid hormones, and it's those hormones that are affecting adversely the patient's outcome. So the concept was right, blocking aldosterone, but in fact it's not blocking just aldosterone, it's blocking cortisol and other hormones at the mineralocorticoid receptor. That's where the action is. That's why spironolactone is a terrific drug, because it prevents both aldosterone and cortisol from having detrimental effects on the heart and the blood vessels. Now, eplerenone is more selective than spironolactone, but in fact that selectivity makes it a little less preferable of a drug, which is why the mortality reduction displayed here with eplerenone, which is, has one advantage. It does not cause either abnormal menstrual bleeding in a woman or breast tenderness in a man, right, which occurs in about 10% of people, but eplerenone is not as good. So the preferred drug is spironolactone, and if somebody gets gynecomastia, nipple tenderness, or vaginal bleeding, you could switch to eplerenone. They're both generic. Eplerenone is more expensive. Spironolactone is dirt cheap, and spironolactone is underutilized. It's a hugely beneficial drug for these patients. And then lastly, in terms of the common pharmacology, reducing heart rate. Why do we want to reduce heart rate in heart failure patients? Somebody did a very, very elegant experiment 20 years ago. They took patients going to heart transplant, and they took the heart that had just been cut out of this patient who was struggling with heart failure and thrown into the dustbin. They took that heart and they said, how well does the heart muscle squeeze in this newly explanted heart of a patient who had an ejection fraction under 20%? And here's what they found. Left to right is the strength of the heartbeat. Vertical axis, strength of the heartbeat. Left to right, heart rate. Take a little piece of muscle, put it in a petri dish, stimulate that muscle electrically to beat and measure its contractile force. In red is your heart, hopefully, because you don't have heart failure. And notice that there's a positive relation. The faster your heart goes, the better it beats. Up until a limit, and in most humans that limit's between 150 and 180. And for an adult, if you have their heart rate at 210 beats per minute, for example, it does not beat as effectively. That exceeds the biologic capacity of the heart. But the reason when you run, you can increase your cardiac output by 4-fold or 5-fold is partly because your heart beats 2 to 3 times more strongly as the heart rate goes up. But look at the green. These are the people who had heart failure. Look at what happens when you increase the heart rate of that heart muscle, independent of afterload, anything like that. Their heart has a paradoxic response. The faster you beat that heart, the weaker it gets. And this explains the paradox, because still in the PDR, if you read, what does it say about beta blockers? It says don't use beta blockers in heart failure because heart failure, may be aggravated by beta blockers. And that's because people only knew about the red curve. And they thought if you slowed the heart, you would make the heart beat less well. In fact, in heart failure, when you make the heart beat less frequently, it actually beats more strongly. At a heart rate of 30, you can't discern the muscle from a heart failure patient who just had a heart transplant from normal heart muscle. This heart muscle has the capacity to beat, but it has been genetically altered because under the influence of the noxious things that go around in heart failure, the dilated cardiomyopathy heart has gone into hibernation, and it's trying to protect itself. So if you slow the heart, you will actually improve the heart's performance. And of course, we have heart-slowing drugs. We've had them since 1962. They're called beta blockers. And there are 4 trials that then used this type of knowledge to ask the question, if we give beta blockers to people with low ejection fractions, do they do better? And these are the 4 trials in the world. The bottom 3 use drugs that you can prescribe today, bisoprolol, metoprolol, and carvedilol. Notice that it's metoprolol succinate, which is the long-acting form of metoprolol. Short-acting metoprolol did not, and I repeat, did not in clinical trials help heart failure patients. We don't know why, it may have been dosing, who knows. But these are the three drugs. The fourth drug in the top, bucindolol, only worked in African Americans and didn't work in Caucasians. So that's why that dot is on the line of unity, the white dot. But what you see is that the outcome, to the left of the line, beta blockers are better. To the right of the line, beta blockers are worse. In all three of these studies, the death rate was reduced dramatically. In fact, the average death rate was reduced 35%. That's better than ACE inhibitors, which is why beta blockers are the cornerstones of therapy for systolic heart failure. They're twice as important as ACE inhibitors, or ARBs, or even spironolactone, right? But the three that are good are bisoprolol, metoprolol succinate, and carvedilol. Now, here is the largest of those trials. 4,000 patients randomly assigned to metoprolol succinate or not. The line of unity is the white line vertically. Every single group benefited on a beta blocker. You could not define a group that didn't benefit. Now, granted, you couldn't get into one of these trials if you had severe bradycardia, right? So if you see a heart failure patient with an ejection fraction of 25% and their heart rate's 41, you're probably not going to give them a beta blocker. And indeed, that was the case in these trials as well. So the one caveat is you couldn't have horribly slow heart rate to get into these trials. So the beta blockers should be cornerstones of therapy. They improve outcomes, both mortality and heart failure stays. And these are the three drugs: sustained release metoprolol, carvedilol, and bisoprolol. Now, one of the common problems that is seen in a heart failure center where we're sent patients in from primary care physicians is that the doses that are used are too low. I mentioned that a little bit about ACE inhibitors and ARBs. It's definitely true of beta blockers as well. You need to drive the heart rate down. Do not worry about blood pressure. I didn't include the slide, but I'll tell you the data. If you randomly assign a low ejection fraction heart failure patient to a beta blocker or placebo, who has the higher blood pressure at the end of the day? It's the beta blocker people. Beta blockers do not lower blood pressure in heart failure patients. They raise blood pressure. And the reason they do, and they raise it 4 millimeters of mercury, is because the heart performs better. If you have more cardiac output, you have a better blood pressure. So numbingly to me, patients are in the hospital, low ejection fraction, and again, the nurse will call me and say, I've held the beta blocker because the guy's blood pressure is 92. Big mistake, right? You don't want to do that. Now, not yet available in the US, but just picked up by a drug company and given fast track of potential approval in the US is this drug, ivabradine, and it is a drug that lowers heart rate without influencing the beta receptor. So this is a different way entirely of lowering heart rate. It goes to the sinus node where your heart rate is originated and directly slows heart rate in the sinus node. And I just want to show you the outcomes trial that used this drug on top of beta blockers to define if you lowered the heart rate more, would the patient do better? And here is the trial. And this just asks a simple question. On beta blocker therapy, if a person's heart rate remained greater than 70 in sinus rhythm, did they do better when they got this drug compared to placebo on top of beta blockers? The vertical axis is the additional risk of leaving somebody with a heart rate greater than 70. For death, 35% more deaths if you left the heart rate greater than 70. 50% chance of readmission to the hospital for heart failure. 50% chance of increased MIs, et cetera. So lowering the heart rate was dramatically better for these patients, even if the lowering of the heart rate wasn't beta blockers. This was on top of beta blockers. Now, one thing they didn't do in this trial was to ask, what if we just doubled or tripled the dose of beta blocker? Would we have had the same benefit? And we don't know that. But my plea to you is if you have a low ejection fraction heart failure patient, using these data and other epidemiologic analyses, get the heart rate into the 60s. That's the safety zone. You want a heart rate less than 70. If you have a heart failure patient come in whose heart rate is 84, you're not doing your job, or the patient's not taking their medicine. Now, granted, sometimes even at maximal dose of beta blockers, you can't get the heart rate down. Try a different beta blocker. People have different genetic beta receptors. Some respond better to one beta blocker than another. Some are underdosed. You may think that the maximal dose of carvedilol is 25 milligrams twice a day. Read the package insert. If the person weighs more than 170 pounds, the recommended dose is 37.5 milligrams twice a day. They don't even make that strength. You have to have them pill split. So I actually have some people who are on 200 of metoprolol plus 75 of carvedilol. And of course you get a call from the pharmacist saying, what kind of an idiot are you, But we're trying to drive the heart rate down. Hugely important for these patients. Now there are other drugs that can be used besides those cornerstones. ACEs or ARBs, beta blockers, spironolactone, those are the cornerstones of therapy. You should have 90% of your heart failure patients with low ejection fraction on those 3 drugs, but some need additional drugs. Digoxin, the oldest drug we have in our armamentarium in cardiology, been used for over 230 years. Nitrates and hydralazine, lower role maybe in African Americans. They've risen to the level of importance, but still haven't achieved primacy. Calcium channel blockers have been used. No help other than rate control for atrial fibrillation. Antiarrhythmic drugs maybe, and we'll talk briefly about emerging data for other supplements like fish oil. So let me just first talk about digoxin. Now, if you're a pessimist, this is one of the first randomized big trials asking drug versus no drug. This is the DIG trial. 6,800 patients with low ejection fraction, half got digoxin, half didn't. Who did better? Well, this is death. The curves are superimposable. So if you're an optimist, you'll say DIG is perfectly safe. And if you're a pessimist, you say DIG is perfectly ineffective, right? This led to people saying, I don't want to give digoxin, okay? Let's delve into that database so that I can hopefully convince you that digoxin still has a role in 2014. First, let's look at heart failure hospitalization. Your hospital is breathing down your neck to keep heart failure patients out of the hospital because they get dinged, and 2/3 of the hospitals in the United States got dinged last year for having too high of a readmission rate for heart failure. Well, here's DIG versus no DIG in terms of rehospitalization. These are the most impressive data that are in the world for preventing heart failure hospitalization. And all they were randomized to DIG versus no DIG. These patients, by the way, were all in normal sinus rhythm. This isn't digoxin for fibrillation rate control. This is DIG as a tonic in people who have low ejection fraction. Furthermore, this is one of the few things where there is a gender difference. Left to right is the DIG level. Now, for those of us with some gray hair, like those of us on the podium right now, we used to drive the DIG level up to like 1.5. Well, guess what? That turns out to be a toxic DIG level. Left to right are serum digoxin levels at trough versus the outcomes, and this is death, okay? So people that had a low DIG level versus medium DIG level versus a level that's still considered therapeutic, 1.1 or 1.2, the death rate went up. In fact, low-dose DIG is helpful, but high-dose DIG is harmful. So if you're going to use digoxin, use it in half the dose we used to use. I very rarely use 0.25 of DIG in these patients. It's 0.125 or 0.0625. And that's particularly true in women. Okay, so this slide is men. Here are women. If you drive the DIG level to 1.1, which your hospital will tell you is a therapeutic DIG level, you've just increased the death rate 26%. Okay? So use DIG, but use it sparingly. Works terrifically at a low dose. And by the way, the reason it works is because it prevents sympathetic outflow from the brain. That's how the DIG works here. Furthermore, it works best in people with the lowest ejection fractions. So EF less than 25, 25 to 45, or the heart failure with preserved ejection fraction on the right, death on the vertical axis. Death is reduced if you have a low ejection fraction, but the greater your ejection fraction is, the less useful DIG is, and it isn't useful for heart failure with preserved ejection fraction. Okay? Now, what about fish oil? Obviously, many of you may recommend fish oil for other reasons, whether it's lipid reasons or cardio prevention reasons. But here are the data from 11,000 post-infarction patients, and this is, of course, an old trial, really from devised in the late 80s, early 90s, before most people were getting interventions and stents and things, so take that into consideration. But if you look at mortality and sudden death, in the dotted line are those people who were randomly assigned to 1,000 milligrams, which I would consider a low dose of fish oil per day, versus no fish oil. Everybody received standard of care otherwise. And what you see is that death was less in the fish oil group. But when they went back and looked at why was death less, it wasn't because the cholesterol was dramatically improved. It was because there was less sudden death on the right. But all of those sudden deaths were in people who had the lowest ejection fractions. And people therefore said, gee, maybe this would be a good drug for heart failure patients. So the study was repeated in low ejection fraction patients, almost 7,000 of them. Death is on the left, red is fish oil, yellow is no fish oil. This is a modern trial. People were already on beta blockers, ACE inhibitors, and death was reduced 11%. And that was with 1,000 milligrams a day. Okay? Then somebody said maybe more would be better, and they did a small trial, which is very provocative, not a big outcomes trial, but they looked at ejection fraction. So let me just tell you, ask the question, how much does the ejection fraction improve for somebody with an EF of 30, and you give them maximum dose ACE inhibitors? Yeah. The ejection fraction goes up 2 percentage points, from 30 to 32. How much does it go up with beta blockers, metoprolol, carvedilol, bisoprolol? 8 percentage points, goes from 30 to 38. With fish oil added on top of those, you got an ejection fraction rise of 5 additional points. That is huge. There are very few things in medicine that have that dramatic of an effect. Going left to right with these green bars, the LV size got smaller, the heart rate went down. That's what you wanted to get, right? The heart rate went down 4 beats. That's really impressive. And then to the right is the last two are how far could they walk and breathe in terms of a cardiometabolic stress test, and the final one is what was their blood pressure. And the blood pressure actually went up, which is a sign of improved cardiac function. These people weren't given 1,000, they were given 5,000 milligrams a day of fish oil, and then after 1 month they were lowered down to 2,000 milligrams a day, and these are data at 12 months after that therapy. So this may emerge as an important cornerstone of therapy, and in our heart failure clinic it is. And we actually follow omega-3 index, which is how much fish oil is in the patient. We shoot for 8%. If they've done that, then we lower the dose of fish oil. Otherwise, we keep them on a dose to rise to that level. Now, other therapies that you might want to employ. Obviously, these patients have lots of arrhythmias, both slow and fast. So sometimes they need pacemakers because they're excessively slow. Sometimes they have too fast. They will therefore need protection against that. Resynchronization, which means a discoordinated heart is recoordinated with multiple wires in the heart. It could be 3, it could be 4. They have multipolar. The electrophysiologists are expert about doing this. Defibrillators, of course, is a safety net to prevent untoward ventricular fibrillation. Maybe replacing things that are deficient. We know that heart failure patients are deficient in vitamin D and iron. And then exercise, and maybe even ablation of PVCs. So let me spend the last couple minutes just talking about that. First, do antiarrhythmic drugs help people with low ejection fraction? Well, in red is amiodarone and yellow is placebo, and if you look at those two lines over 5 years in time, amiodarone is perfectly safe. In fact, believe it or not, it's the safest of the big rhythm drugs we have, but unfortunately didn't save a single life, right? So it's safe but ineffective for preventing death by ventricular fibrillation. In green is defibrillator. Defibrillators help prevent deaths. That's why it's the standard of care for an ejection fraction patient, a patient with an ejection fraction less than 30%. What about resynchronization? If you have a long QRS, bundle branch block, on the left, all bundle branch block patients, 1/3 reduction in death. On the right, those with left bundle branch block. Left bundle branch block patients need not only a defibrillator if their EF's less than 30 or 35, but they need resynchronization therapy. They will do dramatically better. See if I can get this to move to the next slide. Okay. PVCs. You and I mostly ignore PVCs. Somebody did an interesting study. This is like your engine knocking in your car. On the left is the people who had an average of 15% of their beats per day being PVCs. That's 15,000 PVCs per day. And the yellow is what happened after the PVC focus was ablated using catheter ablation in the EP lab. And they went from 15% to 1% of their beats. Look what happened to their ejection fraction on the right. The EF went up 11 points. So PVC ablation, we do that if people have more than 20,000 PVCs per day, but it may be that even people with less than that might benefit. Finally, does iron help? Patients with systolic heart failure can't absorb iron very easily, and hence they tend to be iron deficient. And iron deficiency and anemia, but honestly, each of them is independent. If you're iron deficient but your hemoglobin's okay, you still have a higher morbidity and mortality from heart failure. So somebody said, let's replace iron. Initially, they thought this was to boost the hemoglobin. Turns out that's not how it works. Iron is required by the heart muscle to contract. And if you're iron deficient, you have a deficiency of contraction. So they gave intravenous iron to people who were iron deficient. This is a small trial, but subsequent trials have confirmed it. And again, if you look at the change in exercise, the change in ejection fraction, how the person felt, they did better. So today in our heart failure clinic, that's a standard. We give intravenous iron for people who have iron deficiency and low ejection fraction heart failure. Finally, vitamin D, we don't know. Vitamin D is associated with heart failure. If you have a level less than 20 or 25, you're more likely to have heart failure, but we don't know whether vitamin D supplementation helps. Does telemonitoring and telemedicine help? No. The short answer is multiple trials have shown no help. So, to summarize, what is the state of the art in 2014? Diuretic therapy to correct volume overload. Full dose ACE or ARB, your choice. Full dose beta blocker, trying to get the heart rate less than 70. And then, in our case, spironolactone with therapeutic doses of fish oil. If that doesn't work, if they have a low EF, they get a defibrillator. If you have low EF and bundle branch block, you get biventricular pacing or resynchronization, and we also will replace deficiencies like iron. Now, I'm proud to tell you that doing that in our clinic, our readmission rate for heart failure is less than 5%, our mortality is 3% per year. So these things work, you just have to apply them appropriately. Thank you very much for your attention.
Thanks. Thank you, Rich.
Speak up, Mo. I can't hear you.
Right. Thank you for a great presentation and a great summary. I'm going to fire 3 quick rapid-fire questions to you. Spironolactone, class 2 heart failure?
Yes. So there are emerging data. The original trials used it in the sickest patients, then they use it in the less sick patients. But what has been shown is it doesn't, if they have low EF, it doesn't matter. Obviously, the downside is hyperkalemia. In the big trials that occurred in 2 to 3% of people, in common use in the community, it's about 5% of people will have hyperkalemia. So you absolutely must check a basic metabolic panel. Typically, we check it at 1 week.
Diastolic blood pressure goal in heart failure patients?
So we ignore the diastolic pressure, okay? And part of the reason for that is the slower the heart rate is, the lower the diastolic pressure will be. And you know, this has been an argument about the J-shaped curve, but my retort to people who think you're going to harm people by lowering their diastolic pressure, and I ask them, why is that the case? And they say, well, you might make the heart ischemic. And I say, what's the sign and symptom of myocardial ischemia? It's called angina. And I have never had somebody in this arena where I lowered the diastolic pressure so low that they had angina. So I don't think it's important. Systolic, on the other hand, clearly important.
I want to make a comment on aspirin in heart failure patients?
Yeah, so there was a controversy years ago in which, and this is a truism, if you give aspirin or any non-steroidal anti-inflammatory, you actually blunt some of the benefits of ACE inhibitors. Reason being that one of the benefits of ACE inhibitors is mediated by prostaglandins, and they are in turn blocked by whether it's ibuprofen or aspirin, et cetera. That said, in the big outcomes trials, they could not show any harm for people who had another reason for aspirin. So if somebody has atherosclerosis and you want them on aspirin, and we only use 81 milligrams non-coated, then fine. But don't give aspirin for heart failure because it simply isn't an indication in our view for systolic or diastolic heart failure.
Questions?
Coenzyme Q10, the question is there any role for that? We actually participated in CoQ10 trials in heart failure, could not show benefit. And that originally, that's a 30-year-old idea that has had multiple large trials which have failed to confirm benefit. If you want to use CoQ10 because you think it might help myalgias with statins or something, go ahead. But I wouldn't use CoQ10 simply because the database doesn't exist. So how much iron do we infuse? We give the normal dose you would give for an iron-deficient patient. Now, it turns out Medicare only pays for 125 milligrams per session, so we give 125 IV each week for 4 weeks or 8 weeks, depending on what the iron deficiency is, and then we remeasure the ferritin. Our goal is to get the ferritin above 250.
Do you see clotting dysfunction from the megadose fatty acid therapy?
Fish oil? Do I see clotting dysfunction? I assume you mean anticoagulant effects. So remember, the fish oil story really started back because the Aleuts in Alaska and in Greenland and Canada had lower heart attacks, and people thought that might be an antiplatelet effect. And you can show ex vivo, so if you measure blood before and after fish oil, you can show the blood that's removed and put in a test tube does have antiplatelet effects. However, no trial of fish oil has shown excess bleeding or bruising on fish oil. So does it occur? Yes. Do I think it's clinically relevant? I do not.
Thank you, Rich. Thank you
Okay,
very much.
thanks.